Welcome and thank you for joining us for this special webinar to address two of the most devastating health issues of our time, HIV and COVID-19, and the inequitable impact of those diseases on the Black diaspora. That's the Black community stretching globally from Africa to the Americas. I'm Jesse Milan, President and CEO of AIDS United. Our mission at AIDS United is ending the HIV epidemic in the United States. And our partner for this webinar is Friends of the Global Fight Against AIDS, Tuberculosis and Malaria, whose mission includes ending the global HIV epidemic. And today, this year, both our organizations and all the people and organizations we represent and work with that address HIV are impacted mightily by the COVID-19 pandemic. And all of them that serve Black people or are led by Black people are addressing also the urgent call for racial justice. That loud call includes addressing racial inequities being played out continually in HIV and COVID-19. So today, we will discuss the problem and possible solutions for combating not just the dual pandemics of HIV and COVID-19, but the pandemic of racism that makes our work, their work, and your work so much harder and so very important right now. And we have for you today a select panel of renowned Black leaders from global and domestic HIV arenas who are helping to address COVID-19 and the racial inequities of those pandemics. We introduce them from our partner for this session, my friend, the President and CEO of Friends of the Global Fight Against AIDS, Tuberculosis and Malaria, Chris Collins.
Thank you, Jesse. It's great to be partnering with you on this event. And we do have a great lineup of panelists for today. They include Lois Pace, who is President and Executive Director of the Global Health Council, June Gibson, PhD, who's President and CEO of My Brother's Keeper, Cornelius Baker, Special Advisor to the Office of AIDS Research and PEPFAR Liaison, National Institutes of Health, and Harold Phillips, Senior HIV Advisor and Chief Operating Officer, Ending the HIV Epidemic, a Plan for America initiative. Thanks all very much to all of you for being part of today's event. We're very fortunate actually to hear from a great champion of ours to lead us off, if she's on yet, and that's Congresswoman Barbara Lee. Is Barbara Lee available yet? I don't think she's here yet, so hopefully she'll be able to call in and speak with us in just a minute. We'll just break into the program whenever the Congresswoman's able to come. So let me, for now, then hand it back to what we want to do, Jesse and I, is set some context for today's discussion before we launch into a presentation by Dr. Phillips and then Q&A with the audience. I would also say that later in the program, there'll be an opportunity for Q&A for audience members to ask questions. And to do that, you can start putting your questions in the Q&A box at any time. With that, Jesse, let me hand it over to you for some context setting on the domestic side.
Thank you, Chris. The HIV epidemic has become a Black issue here in America. The issue is, why are Black people so disproportionately impacted? Why are every one of every 2 Black gay men likely to have HIV? Why are Black women 60% of new infections among women? And why are so few Black people aware of and accessing PrEP? Why is the South the epicenter today of new diagnoses and deaths from HIV, and the vast majority of those diagnoses and deaths are Black? We've been asking these questions for years now. And this year, we're asking similar questions about COVID-19 in the United States. Black men and women and children bearing the disproportionate brunt of COVID infections and deaths. Black communities suffering the most. According to a recent AMFAR study, Black people make up a disproportionate share of the populations in 22% of U.S. counties, and those are the very counties that account for nearly half of COVID-19 cases and nearly 60% of all deaths. Those are Black people. The statistics are telling, and the HIV and COVID-19 similarities are alarming. And they cause us in public health and in healthcare to sound the same alarm that's being sounded across our country about the disproportionate impact of systemic racism and deaths and despair caused by police systems and mass incarceration. Historic medical mistrust in Black communities has its roots also in systemic racism. It was not started by the Tuskegee study, but that is one of its most notorious examples. That distrust continues today in clinics and healthcare settings, not to mention the mistrust that drives Black people to not go to clinics and healthcare, whether for an HIV test or for a COVID test. And Black communities' historic lack of access to care and health insurance impede more of us like me who are living with HIV to achieve an undetectable viral load and to live healthier as we age with HIV. That historic lack of access is played out when legislatures across the South are silent about expanding Medicaid eligibility that would especially help poor Black people have more access to care. And I have to say, we hear racist undertones in constant political refrains, strike down Obamacare, which is one of the most important pieces of healthcare legislation in our history that was initiated and nicknamed for our first Black president. Now, the HIV community and my organization, AIDS United, are looking newly at what racial justice looks like across the HIV sector. Initiated in our AIDS United Public Policy Council, we are creating a new racial justice index to look critically at our national system of HIV prevention and care through a racial justice lens. So I'm very glad that Dr. June Gibson, who is on AIDS United's board, is here to give us a picture from the Deep South about racial justice, about HIV and COVID-19. And I'm also very glad that Harold Phillips from the U.S. Department of Health and Human Services Office of Infectious Disease Policy is here also, because we cannot turn around the racial disparities of HIV and COVID-19 without the leadership and partnership of the federal government. Chris, let's hear about the global setting.
Great. Thank you, Jesse. There also is an intensifying dialogue about the legacy of racial injustice in the field of global health, and I'm delighted that Cornelius and Lois are with us today to lead us in a discussion about the global health aspects of this issue. Colonialism and racial inequality are part of the history of global health, and it's important for us to be aware of this history and work to advance just approaches that support people and communities in making health and health services decisions for themselves. This is a time of major disruption in global health. How do we use that disruption to make progress on racial justice in our global health programming? As UNAIDS Executive Director Winnie Byanyima urges us, quote, we can seize this opportunity by learning from HIV and from COVID-19 to make important changes to develop rights-based, equitable, people-centered systems for health, end quote. There's a lot of issues to talk about today and in the future, and those include how to create systems that ensure health services respond to the needs identified by implementing communities themselves, how to promote the voices and autonomy of locally based individuals and NGOs and ensure true partnerships in health delivery, how to deliver more funding directly to implementing communities, how to establish accountability systems that drive progress on racial inequality and advance community autonomy, how to make global health institutions themselves far more diverse, and how to more fully celebrate the leaders in the Global South. And finally, how to make needed structural changes in systems to address history of racial inequality. One of the clear takeaways from the COVID-19 response already is the strong leadership in many African communities and among officials in Africa. Senegal is just one example. It's emerged as a global example of evidence-based responses to COVID-19. South Africa and Kenya are just two other of many African countries which have received recognition for their response. Dr. John Nkengasong, director of the Africa CDC, has led with the science and demonstrated the critical role of that institution. And I'm very happy to say that just today we learned that the Gates Foundation has named Dr. Nkengasong as the winner of a 2020 Global Gatekeeper Award for his, quote, as being a relentless proponent of global collaboration. Moving forward, strong leadership like this needs to be fully recognized, respected, and supported. On a personal note, I'm not an expert in this area. I'm here because our organization, Friends, wants to be part of promoting dialogue in this area, because I want to learn from others, and because I think people with my background have a role to play in making things better, in addressing racial injustice and advancing equality. I'm here to learn what that looks like. Thanks very much. And Jesse, over to you. I think Harold will go next.
Thank you, Chris. And as we continue to await Congresswoman Barbara Lee's arrival, we do want to start with you, Harold. Harold, what is the approach and response at the federal level to the continuing racial disparity for Black people and HIV? And what should we know about the findings in response to the racial disparity of COVID-19? And how do you see the intersection of these two diseases, HIV and COVID-19, for Black people? Harold?
Okay. Thank you, Jesse. And first, I also want to thank you and the team at AIDS United, as well as the Friends of the Global Fight Against AIDS, for inviting me to speak on some of these issues this afternoon, as well as the CBC. In thinking about our work to end the HIV epidemic and where we are with HIV, I think one of the things that we've seen are that there's some true lessons learned that can be applied to our approach with COVID-19. As Chief Operating Officer for ending the HIV epidemic, one of the things that we have realized, and the reason for an initiative such as the Ending the HIV Epidemic Initiative, is the fact that over 30 years of dealing with this infectious disease in America, the system that we created does not work well for everyone. And the Ending the HIV Epidemic Initiative acknowledges that by its call to do things differently, the additional federal investment of funds, and support for bringing the community to the table to really participate in planning and thinking about where health disparities exist. Currently, today, we are sort of stuck and plateaued at about approximately 36,000 new infections annually, with 18.1% of those with indications for PrEP not using PrEP. We also know that there is a disparity that has been created in PrEP in that African Americans, Latinos, as well as Black women are left out of the conversation with PrEP with their healthcare providers and also lack access. We also know that when it comes to things such as access to insurance coverage, minorities lag behind as well. If we do nothing else over the next 10 years, we will end up with another 400,000 new HIV transmissions in the United States, which is why the EHE initiative calls for us to do things differently and think about our approach differently, especially when working with minority communities. Next slide, please. Next slide. So the initiative focuses on the 48 counties as well as DC, San Juan, which account for more than 50% of the new HIV transmissions, and 7 states with substantial HIV diagnosis in rural areas. Many of these areas geographically are populated by minority communities. If you look at this map and you think about the counties and see where they are. Our overall goal for the initiative is a 75% reduction in new HIV transmissions in 5 years and a 90% reduction within 10 years. And when we're talking about a 90% reduction, we're talking about moving from 36,000 new transmissions annually to 3,000 or less. So by targeting our resources in these 48 counties and 7 states, and by applying a different community engagement process, we are hoping to mirror some of the success that we see in many of our PEPFAR countries and our PEPFAR approach of really geographically targeting resources and thinking about service delivery differently. As part of this HHS initiative, we have the logos of the agencies that are actively participating in EHE and working collaboratively and coordinated and administered through the Office of the Assistant Secretary. We also recognize the fact that this overall goal will be reflected in the National HIV Strategic Plan, which will be released later this year. Next slide. And I will speed up a little bit in the interest of time. This slide just gives us sort of demographically another depiction and look at the epidemic in America, with 52% of the new HIV infections being located in the South. So again, another sort of key indicator using data, being able to look at where we need to target resources, where we need to think differently, and also where and how the HIV epidemic is impacting communities of color. Also, this slide speaks to different groups as well, including gay and bisexual men, African Americans, Hispanics, Latinos, and American Indians and Alaska Natives, who have also been disproportionately impacted by COVID-19. Next slide. Thank you. As part of the work that we've been doing in 2020, HHS awarded 9 different projects focusing on the minority community using the Minority HIV AIDS funds. Those projects, which are run through the Centers for Disease Control, HRSA, and Indian Health Service, we also hope will help us better understand different approaches that are both innovative and different models of care and treatment, as well as prevention that can reach the minority communities. Next slide. When it comes to COVID-19, and many of us working in HIV were not surprised when we saw the results and we saw the impact of COVID-19 on communities of color. People with HIV being at increased risk for severe disease from COVID-19 due to both age, as well as folks who are not on treatment and those with low CD4 counts. We really promoted messages to help individuals get in care, stay in care. We took steps to ensure that there was an adequate supply of medications, as well as looked at innovative approaches such as the use of telehealth, which again has been widely embraced in the global setting and has had in the past limited uptake in the United States. But over these past months, we've seen more and more telehealth and telemedicine programs implemented across the United States. Next slide. We continue to also work with our National Institutes of Health to better understand the intersection of COVID-19 and the impact on people living with HIV, as well as ensuring that people living with HIV are involved and engaged in the vaccine trials as well. Next slide. So EHE, ending the HIV epidemic, remains a priority. As such, when we saw decreases in the availability of testing, we took steps to work with our federal partners to ensure that there was additional and updated guidance about the availability of HIV self-test, home test. CDC also revamped its testing guidelines. We also took steps to ensure that there was an adequate supply of HIV medications for both care and treatment and also prevention. We took shifts to ensure and move toward multi-month and encourage multi-month prescriptions as well. Next slide. And all of this was based on both the science and the data, the implementation science from studies that CDC had previously done on home testing and self-testing. So dear colleague letters were updated, additional guidance was provided. We really worked to push these messages forward to ensure that there was access to both HIV prevention, testing, and care and treatment services. We do know that there was and has and will and continue to be a drop-off, which definitely does concern us, and I'll talk about toward the end of this presentation. Next slide. As I spoke earlier about the uptake of telehealth and telemedicine, this is one of those pieces where the genie is out of the bottle. We understand that many patients are liking and preferring this model of both prevention and care. It will be extremely difficult for our provider networks to go back. And as a result, this may be one of the long-lasting lessons learned and impacts from COVID-19 where our service delivery system will be adapting. Next slide. So, the adoption to telemedicine, being able to reach those who are out of care, improving retention rates. The messages about COVID-19, we know a number of service providers were able, as well as people living with HIV who had not been in care, there seemed to be, in some parts of the community, a greater fear of COVID-19 than there was of HIV. Individuals got back into care. Many providers have reported hearing from folks that had been out of care, sometimes for years, sometimes for months, but the messages about COVID-19 and the intersection of HIV was enough to make them reach out, or also people being at home, some folks were easier to reach, so providers took advantage of that as well. So we saw a lot of adaptations as we moved forward, some of which I've already spoken about. There is a concern about the digital divide in that certain groups of folks not having access to the internet, as well as not being as comfortable navigating the internet, may experience challenges in this new virtual and digital world that we have. Next slide. We continue to worry about EHE, HIV, and COVID-19. Without addressing the issues of systemic racism or COVID-19, we are going to continue to have challenges in meeting our EHE goals. The access and continuity of care for people living with HIV, gaps in the ability to refill prescriptions, gaps in our testing services, decreased access to prevention services, as well as the impact of the economic downturn. As the impact on the social determinants of health continues to be realized as individuals lose their job, lose access to health insurance, lose housing, it's going to have an impact on our both service delivery system for those living with HIV as well as our prevention services. Also of note is our ability to collect, monitor, and utilize HIV surveillance data. There have been shifts in the staff that was working on HIV surveillance, as well as the fact that some of our surveillance measures, like incidence, are based on estimates and also previous year's diagnosis. So if we see a decrease in diagnosis in 2020, our data is going to be, and this is an unscientific term, is going to be noisy for a number of years until it sort of straightens out and we can have more accurate models and reliability and confidence in our numbers as we look to end the HIV epidemic in the next 10 years. I think my next two slides are just slides with additional information on how to contact us. as well as information on how to continue to receive updates on our efforts to end the HIV epidemic. If you haven't signed up for our listserv on hiv.gov, I encourage you to, because that's where we continue to update our work. And again, ending the HIV epidemic is still a priority. It becomes more of a challenge with some of these issues around COVID-19. But to have the conversations at the local level about the impact of race, we definitely encourage it, and we definitely know we have to address both at the same time, and that COVID-19 has become part of our endemic. Thank you.
Thank you very much for that presentation. And we'll have time later in the program to dig deeper on there and also take audience questions on that. Remember, you can put questions in the Q&A box. I'm very happy to say at this point that I believe we have Congresswoman Barbara Lee with us on the line. And let me just say, Barbara Lee is someone who really needs no introduction, but I will say she is the U.S. Representative to the House of Representatives from California's 13th District. As you know, she's a champion of many wonderful things, and she's perfect for someone to give comments at this event because she is a champion on social justice, on racial justice, on HIV, and on global health. Really one of the true leaders on all of those issues in Congress today. So, Congresswoman Lee, thank you so much for your leadership on all those issues, and let me turn it over to you for some comments. Thanks for being with us. You may be muted.
You hear me?
We can hear you.
Okay. Yeah, is this Chris?
Yes, hi.
Yeah, hi, Chris. Thank you so much for that introduction, and also for your leadership, and Jesse and Cornelius and everyone on the panel, Lois, June, Harold. It's just amazing, and in one respect that here we are today still talking about the disproportionate impacts of HIV and AIDS as it relates to African Americans, Black and Brown communities. In the midst of a pandemic, when we're still now, unfortunately, looking at the disproportionate rates, again, Black and Brown people, of COVID-19. And you all have, from day one, talked about this epidemic, HIV and AIDS, as a racial justice issue also. So I think people can learn, especially now, given the moment, given the fact that so many are seeing and recognizing that Black lives do matter, that you can help really move this health agenda forward as it relates to the disproportionate rates of health disparities in Black and Brown communities. We all know that people of color are also disproportionately affected by chronic health conditions like diabetes, asthma, hepatitis, hypertension, infant mortality, maternal mortality and morbidity, are less likely to be insured and have less access to health providers. And then, even with access, we're discriminated against and turned away and not treated equitably in the healthcare system. Over the last 14 decades, we've seen the HIV/AIDS epidemic disproportionately impact, as I said, and you said, and you know, impact communities of color, as well as the LGBTQI community. And it's really ironic, it's sad, but the similarities between this COVID-19 pandemic and the HIV epidemic, when it first emerged, is here again. Denial first, something's happening to other people, not recognizing it as a public health issue, and a racial justice issue. So I think in many respects, history has put us in a place where we need to not only continue to beat the drum and make sure that we do achieve an AIDS-free generation by 2030, but also lead the way on how we confront the pandemic of COVID-19. I joined my colleagues, Congresswoman Presley and Senator Warren, in introducing legislation to confront the public health impacts of structural racism. And I hope you look at this bill, H.R. 8178, which is the Anti-Racism in Public Health. And that would work to address racial disparities in health outcomes and really establish a department to look at how racism, systemic racism, impacts public health and how it is a public health issue. And so we've got to rev this up. We've got to continue to fight for our Minority AIDS Initiative funding, for Ryan White funding, for PEPFAR, for the Global Fund, because this is an epidemic that is still alive, and it still unfortunately has no borders, and it's thriving today. But the movement has been so important based on how you all have viewed the HIV/AIDS epidemic in a racial justice construct, and also it was important that we raise these issues, and all of you helped us do this through the International AIDS Conference, which was going to be in the Bay Area this year, and we were able, though, to still do this virtually and raise the issues of racial disparities, and how in Oakland, in my city especially, how we still have the disproportionate rates of the epidemic impacting Black and brown communities, just as we have the COVID-19 epidemic. And so I want to thank you all for your energy and your activism around the virtual International AIDS Conference. But we're going to continue to fight hard, virtually or not. But I hope that you are healthy, stay safe. I continue to be in awe of the power of this community. We have many wins that we can illustrate a roadmap for activists seeking to overcome other challenges facing our world when you look at climate change, inequality, racism, militarism. But the key to all these struggles is organizing around the vision of a shared humanity. I can't think of any better movement who can lead this and who can really help turn the tide than the HIV/AIDS movement, and what you all have done in terms of our organizing, our activists, our grassroots NGOs. You've done phenomenal work. And so just thank you. It's a joy to work with you. And believe you me, November 3rd, we've got to focus on, because this election coming up, and I have to say, everyone says it's the most important election of our lifetime. But I always add that this election is a matter of life or death, and we have got to make sure we get everybody to the polls and vote. So thank you again.
Well, thank you, Congresswoman Lee. You are such a champion, and we are so honored and happy that you were able to join us today. You said the words, Black Lives Matter, and that's really why we're here, because we're talking about the Black diaspora and how HIV and COVID-19 are affecting us across the entire spectrum of who Black people are and where we live. So thank you for joining us. And I think we're going to now start some conversation among our esteemed panelists. And Chris, why don't you start off with the first question for them?
Sure. I have a question for Cornelius, June, and Lois. For each of you, from where you sit each day, what are you most concerned about regarding the convergence of COVID-19 and HIV and the intersection of those with racial injustice? And if you can keep your answer to about 3 or 4 minutes, that would be great. But let me start with you, Cornelius.
Sure. Thank you, Chris, and certainly thanks to the Congresswoman for hosting us here today, and to you, Jesse. I was listening to a lot of what Harold was saying on the domestic epidemic, and so much of it applies to the global epidemic and pandemic right now. And I think that if there are 3 things that trouble me, and where I sit and what I look at, and all of us who are concerned about the global, the first is that we not lose ground. Harold talked about people not getting tested, not getting treatment, not coming in for care, that we not lose ground in our 2030 goals, and that we get people in treatment, that we get people on care, that we have to look at while the lockdowns continue, while mitigation efforts continue, how do we create innovative pathways to get people their medications? We've seen wonderful examples emerging out of India and also out of South Africa of volunteers using motorcycles and getting through the slums to get people their medications, and we have to expand those. The other is that we not lose ground in the vitality of civil society, as Congresswoman Lee was discussing, The community has to be at the vanguard of helping us to get to our end goal, not only in HIV, but certainly within COVID-19. So how do we make sure that our civil society networks and leadership around the world, those organizations are not lost in the economic fallout? The Robert Carr Civil Society Network, which is a partnership of PEPFAR and our European partners in Norway and the Netherlands and the UK, along with the Bill and Melinda Gates Foundation, has done a lot of work over the next 6 months, making sure that budgets can be reordered, that we can make sure that we can send any additional funds that we have in reserve to those organizations to make sure that they survive this period. And it's been something that I've spent a lot of time working with our colleague, as you know, Sandy Thurman, and I work with the Robert Carr Fund for PEPFAR. And then the last area is looking at that we not lose ground on human rights. And this is where we have the intersection of what's surely in our domestic environment now is around racial injustice. And there's certainly a large racial component as we look at the epidemic across the world, but it marries with an intersectionality that I would refer more to as social injustice. And so when we think about populations, whether they're sex workers or gay men or drug users, who during these periods have loss of income, have loss of social support, and have societies that are using this environment to further marginalize them, as we look at what is happening in Brazil. And we have to make sure that this isn't a moment when darker people, when poorer people, when women in particular are not further marginalized and left for dead, quite frankly. And so we have to maintain a vigorous approach on human rights. And we'll talk more about that later.
Thank you, Jesse. I'm sorry, thank you, Cornelius. I'm looking at my list here. June, over to you. And again, the convergence of COVID-19, HIV, and racial injustice. What are you most concerned about regarding the convergence of those?
For me, I'm most concerned with getting lost. I think in the realm in which I live in the South, I feel like I've been in racial injustice for 45 years. I mean, I'm 45 years old. It started from day one. And then I moved into HIV, 20 years ago. And for the first time over the past couple of years, I felt like we were getting some traction. I felt like we were getting some things, under our belt that we were going to be able to handle it. And then along comes COVID. And COVID not only disrupted the rhythm that we had with HIV, it not only shed a light on the injustice. It just brought it all to the forefront. But then it wrecked the economy. And so when things are bad for the other community, it's Armageddon for us. And so it's like we have gone from a tornado to an earthquake to pretty much explosion in our community. And it is the scariest place I've ever been. I feel like we're going to get lost. I know we have been blamed for what's happening to us, which is no different than anything else that we've been blamed for. But because this is impacting so many people, I feel like we'll get left behind. And it won't be the first time we've been left behind, and most definitely won't be the last. I think with healthcare, and again, telehealth, you're exactly correct. Telehealth has really changed things for us. It's opened up so many windows, but there is a digital divide. We don't know how we're going to be able to access it. How will we make sure that once we access it, that we can utilize it, that we're going to be treated fairly? It's not like medical mistrust is going to go away because we have telehealth. So again, now you've added COVID, and we need to go to the doctor. We need to understand our health care. That's not happening. So I am really, really concerned that at the end of the day, Black folks, poor folks, will get lost in COVID. Things will continue to compound on us. And we will perish.
Okay, thank you, June. Lois, and I just want to say that you've been such a leader in terms of convening people around conversations about racial equality and the whole global health movements, and so thank you for your leadership there. What's your thought, going back to the global perspective, about the convergence of COVID-19, HIV, and racial injustice?
Well, thank you, Chris. And I have to say, I follow in the footsteps of people like June. I'm just trying to do my part, given everything and all the things that are happening, like she laid out. You know, I think what keeps me up at night is the onslaught. Right? It's exhausting, and it's too much, and it's a lot of what we've been dealing with for decades, centuries, and then some. And so I think it's important that we just continue to kind of pause and recognize how much it is. I also join her in lamenting the loss or delay of progress in a number of areas, you know, even outside of HIV and the advancements that I feel we were making, that I feel, you know, you, Chris, can even speak to as well. Globally, there are all these other issues that we face around the world, and we're even more at risk for sort of losing ground in those areas given the pandemic. So the ripple effect is real, not just the poor outcomes from the current crisis or the crisis that's in front of everyone else, but all of the other issues and what we see as urgent priorities for our community are really sort of facing us as well. And that it feels like an uphill climb, because it is. But I also, you know, I am not only doom and gloom, and I think people who know me know that I'm not just glass half full, but I really do see a real opportunity here, and I've experienced that through Global Health Council and just by sort of looking up and seeing who else is around the table. There are newcomers here, right? There are people who at least haven't thought about some of these issues together. And what do I mean? I mean, there are folks working on racial justice who are now really keyed in on global health and vice versa. And there are people who are focused on, you know, economic issues that are kind of like really having a better understanding, at least of public health and the interplay there. Again, those of us who've worked to address these social determinants over time understand that relationship pretty intimately, and is particularly those who have experienced this understand that relationship. But now I think it's reached a level of kind of more public, broad understanding that can be really helpful. So with the clash of these crises comes this opportunity to really find common ground across all these issues, and maybe finally address the root causes of how we got here, particularly the disparities across the diaspora, and really start to chip away at, you know, what really is driving the disadvantage of our community and our, you know, lack of access to care and to those better health outcomes that we're all striving for.
Well, thank you, Lois. You just used a phrase that I think was very helpful. How do we get to the root cause? So you all have given us a wonderful overview of what the real problem is and what the disparities are. But let's go even deeper. Let's go even deeper to that topic of systemic racism and how it is actually played out and lived out in the delivery of services, in the accessing of services. Let's go there. And why don't we start sort of at the policy level and then go to the grassroots level. So Cornelius, would you and Harold start us off? And then we'll go to how it's lived out in that community setting from June and from Lois.
Sure. So, you know, look at it from the global framework and look at one of the, you know, big challenges that we have, and certainly that we think about at NIH right now. So within PEPFAR, within the PEPFAR guidance, countries have to work with local activists, human rights advocates, and do a legal environment assessment periodically. Another requirement is to conduct a people living with HIV stigma index. which is to really get to the root of what are the stigmatizations, the actions of discrimination, the actions of racism and other isms that are affecting populations of people that make them more vulnerable to HIV or not able to access services and at risk of death. So last September, we met in New York, Global Fund, UNAIDS, and PEPFAR to create a coordinated response to how we were moving more aggressively to address stigma this year. And we had a wonderful collaborative effort and was looking at doing the stigma index and a reformed, revised stigma index in 13 countries this year, and then thinking about how we put teeth into addressing some of the systemic issues that we see. You know, the current environment has shut down that research. And so we're losing the type of ground that June and Lois just talked about. But we've continued to meet each week to talk about what do we do in this environment so we don't lose that ground. And I think that, you know, Lois, I think, started speaking to some of the hopefulness. And one of the things that last week NIH did an intersectional stigma workshop, and there were over 1,000 registrants on the session. In normal times, that would not have happened. You know, this morning on the HIV interfaith conference between PEPFAR and UNAIDS, there were 900 registrants. You know, if it had taken place during any international AIDS conference, that wouldn't have been there. And so I say this as an example that, you know, we were already committed to these efforts. The pandemic has caused us to rethink what we're doing right now. And at the same time, make sure that we don't lose ground in our research, and not just stigma, discrimination, all of the research portfolio is at risk. And that we don't lose that. But at the same time, we're now being given innovations for new conversations, as Lois said, new people in the room, convening in a different way that isn't involving the cost of travel and expanding the dialogue. So how do we use the period where we're not doing what we planned, but we not lose ground so that when we come out of this, hopefully in a year or so, we're so prepared to go further. And I think that that's the conversation we need to begin thinking about 6 months from now, a year from now. How will we have used this time? And we're going to be reconvening our stigma collaborative next month to look at, okay, now what can we get done over the next year? Because we're committed to addressing stigma, addressing racism, addressing the vulnerabilities that prevent us from ending HIV and people living a long, healthy life.
Cornelius, thank you so much for reminding us that even in this terrible, unprecedented time, there may still be some new equities actually being created if we're intentional about them. Thank you for that reminder. But Harold, you're in a unique position looking at ending the epidemic for HIV, but now having to address the COVID crisis. How do you see that structural racism, maybe from the policy side, continues to exacerbate the problem, if not to encourage it?
So here's what I would add to some of the remarks that Cornelius has already made, and I'm glad that Lois did bring up sort of the look at sort of the potential and the opportunities that COVID has presented to us, because it has brought new players to the table. It has that plus the murder of George Floyd and Breonna Taylor and communities really coming together has also created an atmosphere where individuals, I feel, are ready to listen and learn and seek a deeper level of understanding in the country. And what I've done is encourage, as EHE has encouraged community engagement and civil society engagement, as our global colleagues call it, to really come to the table and have those conversations. You know, I have a master's degree in urban planning, and one of the things that we understand as urban planners is the impact of race and place. And now we are coming to understand the impact of race and place on health outcomes. And so it's things like our U.S. transportation policy that has created disparities in access. It has created disparities in the quality of care. It has not been that long and not many generations where our parents grew up under Jim Crow's rules, North and South, where we had segregated hospital systems and clinics. My great aunt was a nurse in a Black-only hospital in Kansas City. So that memory, that trauma of all of that, the way those systems were created, now is the time to have a conversation at the local level about how do we create a new America with a new system that provides access, that provides quality care, that addresses transportation. U.S. housing policy has contributed to this as well. And so thinking about those things that are really part of systemic racism, and we call them the social determinants of health, but they really are the systems and the policies that have impacted our lives for generations. And it has not been that long when we have sort of called for and said, separate but equal doesn't work for us. And we're still having that fight today. At the federal level, I don't think we have all of the answers, but I'm glad that the communities are coming together and that folks are beginning to listen and try to understand. And now I think we can really begin to think about how do we use the federal funds as well as the state and local funds that we have to really address some of these issues and close the disparities gaps.
Harold, we can't thank you enough for being quite so honest with us about the open opportunities for listening, as well as responding to what you're hearing. But let's go to the grassroots level. June, let's talk about Mississippi. You've got patients coming in the door who are Black people seeking care for both HIV and COVID. How is structural racism played out in delivery in the South?
I think there have been multiple things that have happened. I've recently found out that they don't believe that we actually have structural racism. That's one thing that has come to light, that I'm thinking, in public health, you hear it, it's a part of who you are, and you're like, this is what people understand. And I figured out that they don't understand that we have structural racism because it's been normalized. As you said, Harold, it goes way back. There have been so many elements of how Black and brown people are treated that has been normalized. It's like, this is how it should be. This is how it has always been. Or, we'll give you a little bit here. We'll inch it up a little bit here. But because it has been so normalized, I think it kind of impacted, we woke up a little bit, I'll say that. We woke up in Mississippi. We actually had an awakening. It's like, okay, we have way too many problems. Too many things are happening to us. And so we have to get control over our own lives and what's actually happening to us. And so for the first time in a long time, the patients are calling to make sure they paid their bill. They're calling to make sure that, they're coming back to their appointment. They're calling to see if they can get their test. They want to know what can they do for themselves. And our mental health appointments have gone up. We've been talking about mental health for years, and it's something that we just been offering. But in COVID, it pretty much exposed the idea that you're not well, and that if one more thing happens to us, we're not going to make it. You're going to go down. It can't keep compiling on us. Can't keep coming back more and more. We can't be broke. We can't be homeless. We can't have HIV, STDs, cardiovascular, diabetes, heart disease. I mean, how much more can we take? And so when we saw the appointments were actually changing, that people were coming and they were coming for different things that they really needed, that was one of the highlights of the convergence of what's happening with COVID. And also that the knowledge that all communities and all populations don't believe that we have an actual problem, that some of these things that we're making up, or that if we just do better, then we'll be able to come out of these things. But now that I understand that so many things have been normalized as it relates to our health care and how we live and parenting and all the things that happen in the Black community, I think that's one of our first steps. And what do we do next? What do we spend our time doing? Let's identify the elements of structural racism that have created these inequities, that have normalized these things, and highlight, no, I should be able to have services from the government and my husband or my boyfriend lives with me. I should not be a single parent for the rest of my life in order to take care of my children. So there's so many things that have happened. I think that breaking down what has normalized this system is going to be key for how we move forward with this.
Thank you, June. And Lois, in my travels to PEPFAR countries, I've seen that normalization in the look of hopelessness in waiting rooms, but also the spark of hope in some. How do you see systemic and structural racism lived out in that global context?
Yeah, I think with regards to COVID in particular, there's sort of a tale of two stories so far, and one that's still playing out, right? So there's an opportunity to really course correct. With the sort of upstart of the pandemic, and as it unfolded, I think we all recall the big question about supply chain and kind of who would get to have access to life-saving protective equipment, let alone diagnostics and other really critical resources, particularly for frontline health workers. And, it was really disappointing to have that debate play out in a way that felt maybe not like our best selves at all times. A lot of the wealthier nations who have historically stepped it up in support of Black and Brown communities worldwide were really sort of questioning to what degree they could be helpful or they wanted to be helpful. And I think, worried about sort of the political lens with regards to, sending either supplies or just funding so those countries could buy their own, or frankly, letting them purchase materials from, say, China with money that they had already. I mean, these are the questions that were playing out. And I do think it's indicative of, as Chris was saying earlier, how rooted in not just paternalism, but colonialism, this world of global health really is and can be. And so that was really hard to watch, right? And even harder to try and address and ensure that we sort of stop doing, again, as June was saying, sort of out of a habit. It just shouldn't be a question if and how we help. My worry is that it is now sort of in reruns when it comes to access to treatments and any vaccine that we see from COVID. I think many of us in the space have seen the rallying cries for a people's vaccine, for vaccine equity, for a push against nationalism and what amounts to essentially hoarding, again, of essential resources and services and innovations. And so I would really caution, obviously, any decision makers or policy makers against that urge to sort of keep something for ourselves, if only out of that same self-interest, right? Because it's a pandemic, and we're only going to be as healthy as the least healthy person in the world, because it's 2020. People travel, so do diseases, and it's false to think that we can sort of keep ourselves safe and keep it out. I also, though, see racism playing out even in that kind of language, right? This idea of us versus them and sort of keeping that stuff over there. And we saw it with Ebola, and it almost, it didn't ring true with Ebola, so to speak, but it confirmed people's assumptions that that is something that they have there, and if we just keep them out, then we're okay. And I really, probably for obvious reasons, reject that narrative. And we are seeing it with COVID too, even if we're not seeing it with Black people specifically. I mean, the president was just at the UN again today, or at least his video was broadcast where he is referring to COVID-19 as the China virus. And that is not something that we as public health professionals, and I think as global citizens, want to hear, because we know that it's not just hurtful, but unproductive to our cause, and it's inaccurate as well, right? And so that's racism in real time, and it's certainly something that we're tracking and seeing in our space. I think we are still really grateful for countries and to communities who have rejected those notions largely. We're really glad to see organizations like the World Health Organization bring people together around improving access, equitable access to vaccines and other innovations. But we all have to really watch this space and be mindful of the other side of that coin.
Well, thank you, all of you. And now I want to ask, of each of you, so we've heard, hopefully we're at a moment where people are beginning to hear these issues in a new and more powerful way. And hopefully this is a time where we can take action and start addressing this. So for each of you, what are the solutions to addressing the continuing reality of racial injustice? What, from your perspective, do we need to do it as members of the community, as policymakers? What's the agenda for action in the domestic and global health space? Cornelius, do you want to start us off?
Sure. It's a very interesting question that, and I'm using the framework of stigma as we talk about, and I've referenced it a couple of times, because it really is a way in which we measure the lived experience of people, particularly within the HIV context, and how their vulnerability to HIV develop, which is often along the lines of race and gender. But stigma, understanding and identifying stigma isn't sufficient. Talking ad nauseum about racism isn't really sufficient. And I mean, the truth of it, pointing it out, that's great. But our challenge has to be, what then are we investing in? How are we how are we combating it and its impact? So that we know we're really going to have to identify those within our public health work. And then I think that the other thing is that, and certainly in the global domestic context, what is the legal environment? Because we all operate within a system of governance. And we have to look at how are we truly going to transform law to create better structures. As gay men, we know this from our approach to HIV within the domestic context, that it wasn't just about getting pills to people, also about marriage equality. It's about social equality. It's about what are the affirming laws that get created. And I think that we haven't really yet aligned our work enough on the global level to address our framework around stigma, to then think about what are the interventions, including in the law, that we need to much more aggressively move to support in order to end HIV, but to also not see these repetitive cycles as new pandemics emerge.
Thank you, Cornelius. Harold, over to you. What's the agenda for change from your perspective?
It's a tough one, Chris. I think, like Cornelia said, it's not enough just to talk about these issues. And I agree, especially given what June said about some places in Mississippi, there's still this feeling of, does systemic or structural racism exists. So we've got to have the discussion in order to get folks to really understand what we're coming from, where we're coming from, as well as our lived experience as people of color, and then begin to really think about, now, how do we do this differently, and how do we structure it differently? I do feel that many of the answers that we need about what are the different models and approaches are going to come from the local level and should be coming from the community. I think the agenda for change is, especially where I sit, with the Ending the HIV Epidemic initiative, the continuation of federal funds and support and pushing to ensure that these conversations are happening at the local level and that we are seeing the implementation of change and new models of prevention, care, and treatment to meet people where they are, to do no more harm, and to address the needs that are identified by the community. So for me, that's the agenda for change. And from where I sit, perhaps continuing to push that and also helping to do what I can to help ensure that there are federal funds that support those efforts.
Thank you very much, Harold. June, what are your thoughts on where we need to go, what we need to do next?
I'll actually piggyback off of Cornelius and Harold. From my view, we don't really work in policy. We are grassroots, so we're going to be the ones that I like to prepare people for when policy actually changes. So that's been my role in this. And so the conversations, we have to continue to have them, but I think that we need to have new people in the conversation, people who actually don't understand structural racism. But even when you see the comments, I didn't own any slaves. I wasn't a slaver, but you benefit from the rules of slavery. You benefit from the system that was created based on slavery. So there needs to be some acknowledgement from the masses that racism is real, that all these things are actually happening. And then we move forward. But until the masses acknowledge it, they don't want to hear it. It's like we're beating them down with it. Well, imagine what our lives are like. We're constantly beat down. So the solution is, on one end, is to educate. And to continue to educate, whether you want it or not. You just need to hear it, see it, billboards. We are important, Black Lives Matter. But then once we do all these things, I also want the masses to understand that we're not going to change our minds about you overnight. You've done so much for so long. Mistrust is there. And so give me time to become acclimated to this. It's almost as if Black people need physical therapy. We need years of physical therapy to be able to get back into this and to actually utilize these systems. But just because you build it tomorrow does not mean we're going to come. But do not give up on us. Do not say, well, we've had this for them. They haven't used it. Let's just take it away. Understand what you've done to me has taken so long. You've done it for so long. It's going to take time for me to get into it, to understand it, and to appreciate it for what it is.
Thank you, June. Lois, over to you. And you
everyone.
Go ahead.
Sorry, go ahead, Chris.
No, and you've kind of started off last time with some ideas for action, but what do you see as the top priorities moving forward?
Yeah, what everyone else shared is so powerful, right? And I was really obviously nodding along to everything June was saying, but going back to Cornelius and Harold, and really starting with the people, with the community, that's the beginning of change, right? That's always what the beginning of change really is. I think in our collective experience with social action from the ground up, Chris, you and Jesse both acknowledged in your intro just how rooted this is in a historical context that has endured for years. We at Global Health Council and across the global health community are really aligning around this idea of decolonizing global health. I want to credit the younger leaders in our space for really pushing this issue amongst us. I think with all the do-gooders in our space, there hasn't really been a reckoning of how complicit, if not the actors, the agendas have been in perpetuating the cycle of colonialism. And so to decolonize global health is really to put these people that we are supposedly serving front and center of this work. And turning to them, shining a spotlight on them, elevating or otherwise just getting out of their way so that they can do what they know is needed. And it's really flipping the script in terms of, who's leading these discussions, who's making these decisions, sort of the idea of the participants and their perspectives is fine in terms of rhetoric, but how that plays out, it's really challenging when it comes to kind of a system, including U.S. policies and investments in global health that have been designed the way that they are. But that would be the solution in my mind, is to truly decolonize, again, from the ground up, and ensure that across the board we really have these new faces and voices around the table and otherwise truly contributing to the change we wish to see. I also want to lift up to something, Chris, you offered as just an example of what that looks like, because I think, to June's point, it will take some time for the oppressed to, I think, feel they really can safely step into some of these spaces, right? It's like, wait, I do have control over this? Really? You're not just going to take it back or change your mind or penalize me for speaking out or not doing what you want. So that's a real thing. But I think we're also seeing, as you said, across the continent, for example, there are plenty of countries who took COVID seriously. And it's based on real experience. It's also just based on the wealth of knowledge in the region. And they are showing the rest of the world how it can be done, right? Same with Southeast Asia. And so I think that is, that should tell us there doesn't always need to be a ramp up to that transfer of power, right? And like this idea of capacity building is something that I think has been oft used as a reason to continue to share, if not completely transition that control or transfer that control. But folks are ready, right? And so I think we should certainly look to people leading today and the level of readiness today of Black and Brown people to take on this challenge and to show us what's possible.
Yeah. Can I just add a little bit of what Lois just said, because I think it's really very important, and to think about it in the expectation for change that people have, and what happens if that doesn't occur. A few years ago with MPEP-FAR, the whole country operating planning process was upended to bring communities into that process. And it was very hard. When Ambassador Birx was trying to move that along, there was a lot of pushback. And as a layperson in the process, I had a lot of pushback from a lot of the people who were like, well, this isn't the way you do public health. It's like, well, but it is the way you do community building. And it is the way you get communities invested in an outcome. And that process reached some critical moments where once community was at the table, you had to produce. And you had to show that things were different. And that's where we need to be prepared to also really produce. And so, because that's part of the change, however you define it. And I think that both in the domestic and in the global right now, we're going to be at a critical moment of how do we show that we actually can do things differently and listen to more voices. The last thing that I would say, and I know that for the Congressional Black Caucus, this is always first and foremost, and for all of us and where we are, I was a theater major. I'm not a public health person. I'm in this space because, gay men were dying, principally in the theater, who were my friends. and so had to learn this. But what I know is that what I see is our educational systems are not producing people within these fields that are as sensitive and aware of the communities that we need. And that transformation also needs to occur. So how do we get that investment in education that transforms who's engaged and how they're engaged and what the processes are?
Cornelius, thank you for that. And we're going to go to questions that we received from our really wonderful audience, a wonderful group of people who have been learning from you, but who are seeking some additional information and some ideas. And one of them is about, and I think you just started to hit on it when you mentioned Black gay men, but we know that the Black community is a diverse community. It includes Afro-Canadians and Afro-Caribbeans, and it includes people all across different spectrums of religion and age and backgrounds. Are there segments of the Black diaspora, the Black community, that you are particularly worried about, who might be more constrained or affected by the continuing systemic racism in our healthcare and public health structures? June, I saw you sigh.
Present day right now, I'm very concerned for Black men, period. You know, I think there's a target. I think there is a fear, and again, it's rooted. It's woven into this society and world that we live in, and it's woven like gene material. So it's not flimsy. It's really strong material to fear the Black man or what he brings. So I'm terrified for him. You know, I always fear for Black women because I'm a woman that's overall. I mean, I think that the policing of my reproductive health is atrocious. I think it's gone on too long, and it's not changing. But at the precipice of this, it's the children. We have kids who are growing up in this society, and I don't know if they're able to really conceptualize what's actually happening. I think that they're bouncing between two worlds where things appear to be normal on one end, and then when they go out into the public and they actually have to move around, things change. And I don't think they're ready for it. I think that when I grew up, my mom kind of inserted a fear in me of this world. She knew that things were waiting on me that I had no idea they were out there. You know, she said, you know, before you leave the house, make sure you tell somebody where you're going. So things were just embedded in me. I don't think the kids now have been embedded with, there's still a fear in this world that we have to have. And it's going to take a long time for us to be able to really create some leveling of this. So Black men first, women, but overall the children that we have, they're our future. If we don't have them, then what happens next?
Anyone else? I see some head shaking.
Yeah, I mean, I think that, Jesse, your question, I mean, is two-part. I mean, certainly I agree wholeheartedly with June. And, you know, and for a long time, I mean, I think about, you know, Secretary Sullivan when he began the Black Male Initiative as Secretary of Health and Human Services back in, you know, 1989, was warning about all of these social factors and coming together and how they were affecting the health of Black men. And I think that we are in a period of crisis, and how all of this histories are coming together in Black men. But I also think as we look across the diaspora around the world, you know, whether it's HIV, and certainly as we see it and how it looks, whether it's in the Caribbean or whether it's in the US or the UK, has very similar dynamics. But when we look at COVID recently, You know, there's been a lot made about Sweden's pandemic. But one of the elements that there's not been a lot discussed about, but that you see in other parts of Europe and that you see is the impact that it had on mostly Black migrants and immigrant workers. And so really speaking again to the marginalizations of race and income and where you work. And so so how we really begin to look at the place of Black men and Black people in the world, regardless of their current country of origin, I think is a very important framework that we're going to have, and quite frankly, in the world's interest. Africa has the youngest population. And in 20 years, Africa will also have 2 billion working age people in the most dynamic continent and culture on the planet. We have to make peace with this. And for all of our health and well-being, and wherever we live and wherever we're from.
And the Black community, and I'm going to pull it out from the chat and put it in the center, the Black community has to make peace with our trans brothers and sisters because the disparity they experience because of HIV and the unknown experience they have with COVID, because we're not collecting data on trans people, is quite depressing. We need to own that and embrace that they are part of our community. Chris, is there another question from the chat?
Sure, and thank you, June and Cornelius and Jesse. Also, just want to say you can put questions in the Q&A box. And we've got only about 8 minutes left. This has been great. Before we go any farther, I think Jesse and I both want to say thank you to a few people who made this possible. I'll say from Friends of the Global Fight, Lanice Williams really has been spearheading this for us and done a magnificent job. Thank you so much, Lanice. And Jesse?
And from AIDS United, we want to thank Whitney Thomas and Carl Bologna from our policy team for making all this possible and for working so hard behind the scenes. Thank you. And for recruiting all of our wonderful panelists.
Yes. Wonderful. Okay, we do have a few minutes left, and this is a question from Chantal Mukandali. How can US-based HIV organizations educate about HIV prevention, racism, stigma, and participate in research for people who speak other languages? I think I'm hearing a couple questions in here. One has to do with, I think, language access, and the other is, what's the role for NGOs based here on either the global or domestic effort in terms of addressing the issues we're talking about today?
So
Harold, what do you think?
Yeah, I'll briefly start on that one on behalf of the government. The National Institutes of Health and the Center for AIDS Research, which are both national but also local organizations. We've been doing, I think through EHE, really working to involve community and community-based organizations in that work and helping to actually not only participate in the research piece of it, but also to help set the research agenda. One of the things that I've said as Chief Operating Officer for Ending the HIV Epidemic is the fact that the community needs to drive the research agenda. We need to be looking at our researchers, the implementation science, the evaluators, as helping us solve those problems that are intractable in the community. Cornelius mentioned the meeting that was held last week on stigma and discrimination. I'm really pushing that we look at not only that we don't stop there, but we dig deeper to look at the impact of racism. This also has helped me push a little bit more and thinking about the impact of past and present trauma and what impact it has on health outcomes. And I was happy to hear June say she's seen an uptake in folks looking at mental health services, which is fantastic because our community has held that stigma for so long. And right now, as a nation, we're experiencing present trauma that is causing us to think about past trauma, and it's all sort of multiplying. So yes, that's where we are. And I think that's an answer to that as well. Also, that research happening in different languages as well.
I mean, I want to respond to this less from the research perspective, if I may, and more from the community-based perspective. I'm sure people like Cornelius can add on, but at least the civil society community, right, the network of organizations focused on these issues across the diaspora is quite strong, right? And even across these other groups that we're adding to this conversation, right, whether trans folks, sex workers, there are a range of ways that through the good of social media and the opportunities we have today to be connected, it's really quite robust. And so I think that perhaps a researcher could plug into that kind of community and really see how they can navigate that space in order to kind of access other like-minded individuals who are interested in, again, sharing that information or having that sort of exchange. I think that's readily available, and I apologize that I don't have kind of a name that's top of mind for you, but I think that can happen. I think it is happening, frankly.
And actually, some of our U.S. Research on stigma and discrimination, we borrowed and really sort of learned from international researchers where for years there's been, I think, a lot more progress made in that area. So we've learned a lot, and even at the presentations last week, there are lots of international presenters and researchers. And we still have a lot more to learn as well.
Thank you, Harold. So we are literally at the end of our time together. It has gone very fast, and I'm so grateful for all who have stayed to listen and who have brought these wonderful questions. We're going to give each of you just a quick moment, and I mean a quick moment, to reach back and to say what you would like to say that you haven't said, that you think we need to hear to really change this trajectory moving forward about the impact of racial disparities and systemic racism for HIV and COVID. Lois, let's start with you.
Great, thank you. Again, I just have been so fulfilled by hearing from everyone else as part of this discussion. I think for me, I want to come back to the unusual suspects or unlikely allies. I am heartened even by this conversation and the fact that I have been able to join brothers and sisters in the fight, in the domestic fight, and not just in COVID, but in HIV. And there's just so much synergy and again, solidarity between us that I am heartened by it, and I am lifted by it, and I'm very hopeful that we can continue to hold hands in pursuit of such a critically important agenda. Thank you.
Harold, what about you?
So I will say thank you all. This has been a fantastic panel. Some of the conversations that I think we've been having individually, collectively during this time, as we have sort of struggled with COVID, with it sort of unearthing or just sort of turning over the earth again and making us sort of realize some things that were just beneath the surface that need to be addressed. Something that a colleague of mine said, we need to also realize at this time that we represent the hopes and dreams of our ancestors for self-determination and equality. And while we have come a long way from where they are, there are still some things that we put up with that they would be shocked about. And therefore, we have our obligation to continue to work to make sure these things are addressed so that the generations coming after us can benefit from those who were before us and those who sit in these chairs now. So again, thank you for this opportunity to be part of the panel. Thank you for the work that you all do. Those of you also that have joined us virtually in the community. And let's continue to work for a better day. I remain hopeful.
With that hope, June, over to you.
This was awesome. COVID just kind of sucked my life away. It took so many things away from me that I was accustomed to doing. People I was used to seeing, hey, Cornelius, good to see you. But within it all, this is really, in COVID is the first time I actually talked about race. I live race. Race is just who I am, it's just what happens, but I never really talked about race. And the first time I actually talked about race a couple of months ago, I didn't realize how actually angry I was about race, how angry all of this has made me, how overwhelmed I am, how it's like really this now. And having the opportunity to talk about it, we can't stop. I need to talk about it more. It has to be something that has to be heard over and over again. We can't make this stuff up. This is actually the lives that we've lived and the lives that our children have lived and our parents and grandparents. And for the first time in 20 years, HIV hasn't been my forefront. Race has become my forefront. And I don't think it'll ever go away at this particular point. So I enjoyed it. Hopefully we get other opportunities to do things together. This was just absolutely awesome. Thank you, Chris. Thank you, Jesse, Harold, Lois, Cornelius. This was great.
And Cornelius, your life's work has transcended global and domestic. A final word?
Well, thank you all for this very interesting conversation. I hope that our people who've joined on, and it's been a great over 150 people on today, and that's really wonderful. I guess I just want to, for my last comment, end it by saying, next week I have a birthday, and I think about 39 years ago, preparing for a birthday in the beginning of the HIV pandemic and thinking it would be maybe the last one. And things were upended and we were fearful and we didn't really know. And there was chaos and a lack of leadership. And we survived it. And we still don't have a vaccine. We still don't have a cure. We still have work to do. And we've lost way too many people. But we have stayed with it. And we have made things better. And I just think that, like Harold said, our ancestors, they stuck with it. And there was a lot they had to stick with. And so, but I do think that one of the things that I think for all of our people working, particularly our civil society networks and globally, part of the response has to be we ourselves. One of the things I'm most inspired about with the young people protesting, even though I get a little concerned when they're not socially distanced out there, is how they rejected the looters, how they rejected not including the trans people, how they rejected when people question why gay men were involved. The younger people were very clear. Black Lives Matter means all Black lives. On our global response to HIV, all of our institutions and governments and others within a Black diaspora are going to have to come to that same conclusion. It's not just about how we act against the other, but how we act with ourselves, because that we can govern. And I think that this is a moment for us to come together in that space as well. So, pandemics reveal things and they clear out things, but they also can make you stronger for what you didn't know you were prepared for. And I think that we have to take on the inner strength of all of our ancestors to get across this next river.
That river is populated with tears. We have, out of the gloomy past, but the present needs a change. Thank you all for the work you're doing. Thank you on behalf of AIDS United and our partnership with Friends of the Global Fight Against AIDS, Tuberculosis and Malaria. Thank you to our team for all the hard work. And I'm just going to tell you that when Chris and I thought about this, we thought if we can pull June and Lois and Cornelius together in one spot, we will have done service to the world, and I hope we have. Thank you all for being on this panel. Chris?
Thank you so much, everybody. This was awesome. Let's keep talking.
Let's keep talking. Thank you all, and thank you for joining us. Have a great evening.